Good afternoon, good morning for those joining where it's still morning. Welcome everyone to this Public Health Agency COVID-19 Emerging Issues webinar. My name is Yoav Kainan and I'm the Scientific Director at the National Collaborating Center for Infectious Diseases. I will be your moderator today. The NCCID is funded by the Public Health Agency of Canada in order to provide knowledge and evidence for public health planning and support the agency in knowledge translation during the COVID-19 pandemic response. I would like to acknowledge that the NCCID is located in the University of Manitoba, original land of Anishinaabe, Cree, Oji Cree, Dakota, and Dene people, and on the homeland of the Métis Nation. We have a busy webinar today with fantastic presenters and discussants, so I will keep the housekeeping notes for minimum. The event is a moderated discussion. We're running the webinar on Zoom. If you have any technical issues related to the Zoom platform, please contact us by email on nccid@umanitoba.ca. To make most of the time today, we have prepared questions for the panel for discussion in advance. Some of those questions come directly from you in the pre-registration survey. Thank you for all those who provided questions and shared them with the panelists ahead of time. You can use the Q&A function during the session to submit additional questions for the panelists. We will not have time and will not be able to address all of your questions in today's sessions, but those questions are really important for us as they inform future webinars and development of additional activities with the Public Health Agency of Canada and NCCID. Speakers and hosts will use the chat tab for extra communication with attendees if need be, and we'll keep our eye on the tab as well. The webinar is recorded and the presentation slides will be available shortly after the webinar is concluded at nccid.ca. I will now turn things over to Megan Pacha, who will make brief remarks on behalf of Public Health Agency. Megan is the Manager of Vaccine Confidence Policy Research Engagement Team at PHAC. Thank you, Megan. Podium is yours.
Thank you, Yoav. I want to thank you all for joining us today. Many organizations and associations, including the Public Health Agency of Canada, have been working for the last several months to increase Canadians' confidence in COVID-19 vaccines specifically. But this is by no means a new issue. Vaccine hesitancy long predates the pandemic, and I'm pleased to see that so many of you have joined us today to hear from a panel of experts who will discuss vaccine hesitancy from various perspectives, as well as some strategies to address it in a clinical practice. So I will start by giving a very brief overview of our event today. So today's webinar, we hope to provide an overview of COVID-19 vaccine hesitancy, the factors that can contribute to hesitancy, and how experiences and attitudes may vary across key communities and population groups. We also aim to support healthcare providers in understanding the various ways in which patients might express their hesitancy and how to respond in ways that will build vaccine confidence. And finally, we would like to use this opportunity to introduce a new resource that's available on evidence-informed strategies for addressing vaccine hesitancy that you may wish to refer to. So in a few moments, I'll turn it over back over to Yoav to provide some high-level remarks before we'd open it up to the panel. But I would like to start off with some context behind today's webinar. So while there's a great deal of discourse on vaccine hesitancy in the context of the current pandemic, vaccine hesitancy is neither new nor limited to COVID-19, as I mentioned. It has existed since the advent of vaccines centuries ago and has undermined the public health impact of vaccination programs since then. And although addressing vaccine hesitancy has been a part of PHAC's regular business for many years, this work has certainly taken on a new significance and a greater complexity in the context of COVID-19. So research is very clear that healthcare providers are trusted voices within their communities, and we know that you can make a real difference in individuals' decisions about vaccination. For example, a study from Abacus in November asked vaccine hesitant individuals which factors might influence them to get vaccinated. And at the top of that list was encouragement from a family doctor. Similarly, research from the Cosmo Canada study has found that throughout the pandemic, Canadians consistently point to their healthcare providers as among the most trusted source of information on COVID-19. So it's for this reason that a core component of our federal vaccine confidence strategy at the Public Health Agency of Canada is to provide vaccine information, training, and other supports to healthcare providers to ensure that they're confident in their decisions to vaccinate and in recommending and administering those COVID-19 vaccines to their patients. In our engagement with healthcare providers and health professional organizations over the last year, we've learned that there was a clear need for additional training and resources related to addressing COVID-19 vaccine hesitancy in particular. And in a survey of over 14,000 healthcare providers that the agency conducted back in December of last year, 95% of respondents indicated that this kind of training would be useful for their practice. Many respondents who administer vaccines or provide education on vaccines said that they would like support in having discussions with their patients about vaccines, including via scripted answers to common questions and concerns. As healthcare providers, you clearly recognize the importance of addressing vaccine hesitancy and the need for training and resources to support you in your clinical practice and beyond. And this is a large part of the impetus for today's webinar. Just lastly, I want to mention that PHAC has developed and made more accessible a variety of training opportunities and resources for healthcare providers, and particularly for those who administer vaccines or provide vaccine guidance and education to patients. There is, of course, this webinar series for healthcare providers. Today's webinar focuses very specifically on vaccine hesitancy, while other webinars aim to build or affirm healthcare providers' confidence in COVID-19 vaccination by addressing key questions about specific COVID-19 vaccine products or vaccine safety, NACI guidance. PHAC has also worked with the Canadian Pediatric Society to increase the accessibility of their online education program for immunization competencies, or EPIC, training, which now also includes a COVID-19 vaccine hesitancy module developed in partnership with PHAC. And we would encourage you to look into this online training if you haven't already. And then finally, there's our COVID-19 vaccination resources toolkit for healthcare providers. This online toolkit includes resources on a range of vaccine-related topics and in many different formats. The most recent iteration of the toolkit was published in early May, and it contains a new resource specifically on addressing vaccine hesitancy in the context of COVID-19. So this primer, as we've called it, provides an overview of vaccine hesitancy. It also outlines guidance and evidence-based strategies for healthcare providers to respond in ways that support vaccine acceptance, both through communication with patients and through workplace initiatives. There are also some examples of scripted responses included that showcase what these evidence-based strategies might look like in action. So the primer and today's webinar are meant to be very complementary. It's our hope that in bringing together our expert panel today and learning from their perspectives and experiences, we can bring some of the principles and strategies of that primer to life. And without further ado, I'll turn it back over to Dr. Keenan, our moderator, for some stage setting. Thank you very much.
Thank you, Megan. So I will go through a bit of the principles and some of the concepts related to vaccine hesitancy. And as the vaccine hesitancy has been defined by WHO as reluctance or refusal to vaccinate despite the availability of vaccines. And as most human behaviors, there is a spectrum that starts with acceptance of all vaccines with confidence and full trust, acceptance with some uncertainties, accept, but some comprehension and some reluctance with delay and some refusal, to individuals that refuse but are open to conversation, and in the extreme end of the spectrum, individuals that refuse all vaccines with conviction. And research shows that individuals who typically accept vaccines have unique concerns about COVID-19 vaccines, leading them to consider delaying or thinking more, or having a longer contemplation phase when it comes to COVID-19 vaccination. Next slide, please. The factors that contribute to vaccine hesitancy are complex. It's not one factor that influences the vaccine acceptability and confidence. And hesitancy is composed and has been labeled with the 5 C's. One is confidence, the level of trust in the fact that the vaccine actually is effective and it works in protecting against the disease, and understanding of the safety of the vaccine, a system that delivers the vaccine. And those are really important in determining the likelihood of individuals wanting to get the vaccine. Complacency is the second C, and it's the perception of vaccine preventable disease. Is it low and vaccines are not necessary? And if my risk is low, there's a sense of complacency. The one that I want to emphasize is convenience, where, as I outlined in the previous slide, most individuals are on a spectrum from high likelihood of taking the vaccine with few questions to no acceptance of the vaccines. But in the spectrum, availability and accessibility and removing barriers to access vaccines are critical, as convenience plays a huge role. And we have some speakers in the panel that I will introduce later that can address some of the specific populations and specific barriers and needs to overcome some of the convenience issues. Calculations, individuals engage in extensive information searching and finding and evaluating risks of infection versus vaccination, and that is impacted dramatically by the over flooding of information that may not necessarily represent the real risk and benefit of the vaccine, and misinformation plays a role in impacting that. And collective responsibility is the extent to which one is willing to protect others and understand that your own vaccination is important for public health. Next slide. What do we know about COVID-19 hesitancy in Canada? So public opinion research shows that most Canadians are intending to get immunized. Intention to vaccinate against COVID is increased in recent months. Some Canadians prefer certain COVID vaccines over the others, and that is an important point, that is not all vaccines are created equal. And data from April and May shows that 40% or so have been immunized, at least one dose. A third of Canadians intend to get the vaccine when they're able, and a smaller proportion intend to get the vaccine but are slightly sitting and waiting on the sidelines. 10% are saying that they won't get immunized, and that number has not shifted during the past few months. The other part that is important, that certain subgroups are more likely to express vaccine hesitancy, and I hope that we can try to discuss this in a bit during this panel discussion, is young adults, women, Indigenous peoples, Black Canadians, newcomers, and parents or guardians, children younger than 18, and groups that intersect several of those characteristics. So those are really important if we want to tailor our vaccine to and to try to decrease the hesitancy. Next slide, please. What role does intersectional factor play and access barriers play? So many racialized individuals, histories of lived experiences of stigma and discrimination impact the likelihood of having trust in the healthcare system and access to the healthcare system for immunization. Newcomers have challenges navigating the health system, including language barriers, access to technology, registering online for vaccination and other things that influence the likelihood of making an appointment, greater exposure to vaccine misinformation and disinformation on social media, mistrust of government, and particularly if coming from places where government was not to be trusted because of many reasons such as oppression, corruption, etc. Many of the individuals that are reluctant to get vaccines are on the lower socioeconomic strata, part-time or contract work, low wage or employment benefit, and barriers to accessing healthcare system occur in general, and juggling the previous work commitments and family commitments, frequently with multi-generational families. All of those together put some barriers in place of getting a vaccine. Women, competing domestic responsibilities for childcare, work, and those are really concerns that have been specific and shown more frequently in women. Concern about vaccines' impact on fertility. We've seen that in some devastating examples in Manitoba recently. Other things that the need to take unpaid sick leave for side effects of the vaccine and no options to work from home if in the case that you have some side effects related to the vaccine are also concerns that have been raised. The takeaway message for from this complex slide with lots of text is that vaccine hesitancy is complex. It's a spectrum and it has multiple factors that play into it, and it's beyond the issues of confidence, and some of it related to issues of access and our responsibility to try to remove barriers that affect some segments of the population. Next slide. What potential challenges lie ahead? So obviously we want to try to encourage most adults, as many as possible, that can get vaccinated to do so. We want to support individuals to make it to the second appointment and complete the vaccination. We want the parents and guardians to accept vaccines and to hopefully increase our ability to reach a young population with vaccines. And that's been a challenge in other countries. After the older adults have received the vaccine, the younger population's been tougher to entice to get immunized. And then we will have more challenges ahead with some fatigue and the likely need for future vaccination and boosting of the vaccine. That will be a different challenge, and we'll leave it out of the discussion today. So there's high acceptance among adults in Canada, and that is encouraging. There is a strong group that will not be shifted in their opinion, but there is a large group of individuals that can be swayed to get the vaccine with proper education and removal of barriers to vaccine administration. Next. I think that with that, I will, after setting some of the stage, thanks Megan, and I would like to introduce our panelists and take us to the panel discussion and leave as much time as possible for our more interactive segment of the discussion. The first panelist is Dr. Cora Constantinescu, who's a pediatric infectious disease specialist working within Vaccine Hesitancy Clinic at the Alberta Children's Hospital in Calgary. Thanks for joining us, Dr. Constantinescu. The next participant is Dr. Akwatu Kenti, who is an assistant professor at the Dalla Lana School of Public Health at the University of Toronto and a chair of the Black Scientist Task Force for Vaccine Equity in Toronto. Welcome, Dr. Kenti. Claire O'Gorman is a registered nurse and language translation specialist in immunization at the National Collaborating Center for Determinants of Health and is based in Calgary. Welcome, Claire. And Dr. Meb Rashid is the medical director of Crossroads Clinic, a medical clinic that serves newly arrived refugees housed in a women's college hospital in Toronto. Welcome, Dr. Rashid. So with that introduction, I will switch to the moderated discussion. And again, the questions here come from your from a curated list of questions from the Public Health Agency, as well as questions that you have submitted during your registration. The first question is open to all panelists, and in some cases, people can be quite vocal about refusal to vaccinate and oppose vaccines in general, but in many cases, vaccine hesitancy is quite subtle. What are some of the subtle indicators of vaccine hesitancy that you see in your work, and how do you try to overcome those or manage those? Dr. Kenty.
Okay, I'll go first. The most common expression that's subtle, I would say, is the waiting. I've heard it in many ways. I'm waiting for the vaccines to be approved. I'm waiting for more people to take the vaccine and see what happens. I'm waiting for Pfizer. I'm not going to take the AstraZeneca. I'll wait for the better vaccine. And so I think this waiting expression is a subtle expression of vaccine hesitancy. I emphasize that all of the vaccines that's been approved have gone through all the processes, protocols, and practices that ensure safety. Not only that do they ensure safety, they involved a very significant segment of racialized populations, especially with Toronto, the Black population. Approximately 9% of Black people were involved in all of the vaccine trials, which is unprecedented, not just for vaccines, but for traditional medicines as well. I highlight the risk of waiting for COVID versus the risk of the vaccines, showing the discrepancy. And I drive home the point that within 8 weeks, we usually know what the effects of a vaccine are going to be. And up to now, millions of people have been vaccinated. We have incredible amounts of safety data, robust safety data, so telling us very clearly that the vaccines are safe to use. So take the first vaccine that comes your way.
Thank you for those comments. Maybe I'll go according to the screen I see. Dr. Constantinescu, what are some of your approaches?
Yeah, so this was great. So the waiting is a really big one. I would say we see two other groups. One is the people who feel that one size approach fits all just doesn't fit them. So they feel there's something different about their personal history or their family history that makes them somewhat exceptional when it comes to the vaccine and possible vaccine effects. The other interesting group that we've come across who are not really opposed to vaccine and who recognize that COVID as a disease is a very significant threat to their lives are people who also feel that they've been so compliant with the public health recommendations, they feel somewhat safe in their isolation, which is an interesting phenomenon for many of us because we do know that when the numbers are a bit high in the population, nobody is really safe, but this is where they come from when they approach this issue. And what I found really helps is that this understanding that these people are trying to make the best decision they can to protect themselves and to protect their families. And they are overcoming quite a lot of anxiety and fear. And it's quite brave of them actually to approach healthcare providers about it, because this is something that can be very pervasive for them and a constant source of stress. So what I find helps in how we try to approach them is to first of all, create a connection. So that idea of building trust with them. So can we understand a bit more about their families, about their situation, and validate some of the emotion behind the reasoning for this? And then the next component of our approach is to meet them where they're at, which is difficult because sometimes you want to meet people where you want them to be at, but just a recognition that where they are is where they are, and we need to meet them exactly at that. And like Dr. Kenty said, you have to approach them in a very personal way. So the conversation has to be around their actual reasons, not in an ideological sense, but in a very personalized approach. So how is the vaccine a benefit to their family, to their life and their situation? So we find those are kind of our main approaches: finding a way to connect, finding a way to meet them where they're at and validate their emotion behind this, and then keeping the conversation very personal.
Thank you, Dr. Constantinescu. Dr. Rashid, maybe some of the perspectives from a newcomer would be welcome.
Yeah, I would just echo what my colleagues have said. I think, most recently I've been hearing that quite frequently, is that I haven't made up my mind yet. I want some time to think about it. And I think, for me, it's also important to recognize there is such a power disparity that for a lot of those people who speak in those terms, some of those, and again, it's a variable group, but for some of those people, they just don't want the vaccine. They're not going to get it, but they're too polite to either discuss it with me, or they recognize the fact that we may be coming from different places. Others, have really have issues they want to have addressed. So I think for me, it's really important when I hear that to recognize that there's probably a lot under the surface there that really needs to be teased out. The other thing we find with our patients, and I think this is probably similar across the country, but certainly in Toronto, the newly arrived immigrants and refugees we're working with, they're often the ones who are on public transit, going to their factory jobs. They are the ones who often cannot isolate. And, so I have that conversation saying, for many people out there, who are able to work from home, who are in a different socioeconomic class, really the rates of vaccination are quite high. And that for me, it's really humbling and in some ways quite sad that we're seeing people who in many ways are keeping the economy going, putting themselves at risk. They're the ones delivering our food and, the Amazon delivery people. And when they're hearing information that is discouraging them from getting the vaccine, it's really important to put that in context, that they often are people who are very high risk. So for me, it's always a bit of a reminder that, when people are not sharing their reluctance, that my job is to try to sort of dig deeper and see why. And for some of those folks, we've been able to overcome what issues they have.
Thank you very much. Claire.
Yeah, in addition to my work around the determinants of health and vaccine access, I also work at the mass immunization clinics here in Calgary. And interestingly, folks will come to those clinics without their mind always made up. A vast majority are there, they're excited, they're ready to get vaccine. And some people arrive with questions, and you can tell that hesitancy, you can tell that nervousness when someone sits in front of you and they maybe need a little more information. And interestingly, because of that power dynamic you spoke to there, sometimes people are hesitant about their hesitancy and they don't know how to bring it up. And so as a provider, for me, it's really important to say, you look a little nervous today, something going on, and start with a place of curiosity. What is it about the setting we're in? The site I work at is a huge convention center. There's lots of people, lots of noise. Sometimes it's the stimulation from the environment. Sometimes it's a needle phobia. Sometimes they're like, well, I thought I could get Pfizer today, but you guys only have Moderna. I have questions about that. It's making me nervous. And so opening the conversation, acknowledging and validating those feelings, and starting from a place of curiosity about what it is today that those particular needs are. And as my colleagues have said, making it really personal, building that connection, building that trust, and taking the time to do that, even in a setting where we're trying to get through lots of people as quickly as possible, is really important to overcoming some of that hesitancy.
Thank you all for your insights into that. And the next question is about the term infodemics used to describe the mass information, unprecedented information, some of it good, some of it not so good, especially on COVID-19 and COVID vaccines, that people have various sources to access, including social media. How have you seen the infodemic effect on patients' attitude on vaccine likelihood of taking the vaccine, and what are some of the ways to help patients navigate this mountain of misinformation? In this question, I'll start with Dr. Rashid.
Great. Yeah. So this has been a huge issue in the population we serve. And I mean, there's so much information out there in all realms, certainly for the vaccine and healthcare altogether and politics and social policy. You know, my wife says if I'm buying a blender, it takes me hours to go through the reviews. And so how to sift through information, I think, is one of the great challenges for our generation. My experiences with the COVID vaccine, at least discussing with my patients, go back to about December, January, where for every appointment we had, we would end it by asking people if they had any questions and if they were open to taking the vaccine. And quite amazingly, I would suggest in those early months in December and January, about 80% of our patients clearly said no, they're not interested. And it was a real testimony as we dug further. It was a real testimony to the fact that they were getting information on social media, often from physicians, people in their own language, and that information was landing, right? So we had lots of questions about fertility, about will this affect my DNA? Why were the vaccines licensed so quickly? And it was obvious that social media had been quite effective in putting out misinformation. It was also quite apparent that we were late coming to that, right? As a clinic, we just weren't ready. And so we went all in. We probably done over 20 webinars for our patients, for the community, for settlement workers, people working within the community. We put out information sheets, bulletins, working with some other organizations and had them translated. And that was really our mission in those first couple of months. I had a bit of an epiphany in April. I spent a couple of days calling patients of mine. Now in Ontario, I think it was people over 55 who were eligible at that point. And it was interesting. I remember one day going through about 50 or 60 patients, and you know how many said no to the vaccine? Zero. Right? Absolutely zero. Now again, there's for a multitude of reasons, but it really occurred to me that, I was talking to some people who had worked in long-term care, really ground zero for this pandemic here in Ontario. They'd been offered the vaccine. They said no. When I called them, discussed it, they said, absolutely, book me an appointment. And what was it? It wasn't coding efficacy data. It wasn't dealing with, why the vaccine was marketed so quickly. It was often as simple as, doctor, do you think I should take it? And I'd say absolutely. And they said, good, book me an appointment. And that in Ontario is an adventure, right? Booking an appointment is an adventure. And I think, we've realized for our patients, having them sign on is great, but then we've really got to do the work to get them that appointment time and date. So it's very labor intensive. Now, at this point, I would say probably about 80% of our patients, if not higher, are more than happy to get the vaccine. Just over the last couple of weeks, I've been shocked that people are calling us to book them an appointment. And that certainly wasn't happening a couple of months ago. So I think what I'm learning is, the what is important, like what information we need to give to people, and we need to be well-versed. And, I know Megan spoke about some of the resources that are out there. In Ontario, we have some fantastic initiatives to keep us educated as healthcare workers. But what I'm learning is that, it's really about trust, and who is providing that information to me is really the most important thing. And, as healthcare workers, and particularly as people who work with our patients continuously, I mean, family doctors and nurse practitioners, we have a tremendous impact. And, I think where we've landed in our clinic is, how do we sift through that information? Well, we're making one-on-one phone calls to discuss the vaccine. We're working our way through, thousands of patients, but we find that, really it's been highly effective. In terms of the information itself, look, one, it has to be accessible, and that means it has to be language specific information. But I would suggest it can't just be that. I've seen fantastic websites that have a tremendous information. It's translated, but I can tell you none of our patients have been on those sites, right? And they're fantastic sites. I think the onus for us is to actually recognize where immigrants and other vulnerable communities are going for their information, and to tap into those sites. So, when I go back to December, January, I was hearing about things on WhatsApp, YouTube, YouTube videos being put together by physicians in other parts of the world in Arabic that was infiltrating the, Arabic speaking community here. I go to the Public Health Agency Canada or CBC or WHO or CDC. That's not where our patients are going, right? And I think we've got to be conscious of that and be able to use the platforms that they're actually using. Overall, I'm really optimistic that people are getting that information, and it's a real testimony to all the work that that people are doing. And it feels very different to me in May than it did in December and January. So.
Thank you for this answer, Dr. Rashid. I will move to the next question just so we can cover as many of the numerous questions that are here. And it is a good segue to Claire. Discussions on vaccine hesitancy focus on one-on-one encounters and the power of that recommendation that Dr. Rashid outlined. But how do we go about some of the ways to address vaccine hesitancy on a more population level?
Yeah, and thanks for the question. To me, when we step back and look at population level interventions, at that point, I think we're really talking about the social and structural determinants of health. So while individual hesitancy is really important, I'm concerned that by focusing on hesitancy, we neglect to consider the other interventions and strategies that are important for assuring vaccine uptake. So that convenience piece that you spoke to earlier. As my colleague here in Calgary, Dr. Fabro said, if vaccine hesitancy is all we focus on, it actually avoids the uncomfortable truth of an equitable distribution. So across Canada, we've seen that communities with the lowest levels of vaccine uptake are also those with the highest COVID rates. They're often communities of essential workers where online booking and appointment-based clinics just simply aren't accessible. Largely vaccine rollout has really failed to consider the social and structural determinants of health, especially the ongoing racism, colonialism, and classism that's perpetuated through our healthcare system, and the mistrust, rightly so, that many communities have with both science and health. There's research and modeling that demonstrates even if we simply directed vaccine to the areas with the highest rates of COVID-19 transmission, this modeling from Ontario demonstrates that we could prevent 10 to 15% of hospitalizations, ICU admissions, and deaths. So it's really important that we're being really strategic in how we roll this out. It's really key that we're addressing this inequitable distribution by consulting and partnering with community leaders. There's certainly not a one-size-fits-all approach, as has been said. But broadly speaking, though, we need to develop strategies that first address this mistrust and secondly address this access piece. So at that systems level, building trust can be done by optimizing vaccine access for trusted healthcare providers. As Dr. Rashid said, the folks already having these conversations in community. As Dr. Kenty said, that waiting piece is huge. And if people are going to wait, they might defer or decide to never go. Whereas if we can close that gap between the conversation about the hesitancy and actually getting it in someone's arm, that will reduce a huge amount of barriers. We can, ensure that community agencies and community leaders are at the decision-making tables and can help actually roll out vaccine, whether that's hosting a clinic, identifying community ambassadors, identifying ways of providing culturally safe care. Those agencies really need to be at the table and be partners in this work. We can also, really improve access by embedding ongoing opportunities for vaccination into spaces and places where people already spend their time. So places of worship, community resource centers, schools, the streets, really getting it out there in a really low barrier way can make it convenient, make it something that's really easy for people to do. And it absolutely needs to be available on that walk-in basis. Appointments are so prohibitive and such a barrier for so many people. And I really think ultimately, local public health units, community agencies, and family physicians are not being funded or being given the decision-making authority to implement the strategies we know work. None of this is rocket science. Communities already know what works for them. They just need to be given the resources in order to do it.
Thank you very much, Claire. I second this empowerment of community to they know where and how to reach and how to educate. So I think those are important points. Next question I will direct to Dr. Kenty on we know that a large component of confidence, including trust in health institutions, trust in government, and trust in vaccine manufacturers. Can you please speak about the factors that shake the trust among some of the communities that you work with, and how can healthcare providers build trust in those communities?
Yeah, thank you very much for the question. And historic experiences, as well as contemporary experiences of racism, really are the shaping factors or the key influences of opinion in Black and racialized populations. But I'll speak primarily of the Black population of Toronto, because I've been involved in a series of town halls, almost one a week for the past 14 weeks, targeting different segments of Black communities from Africa, from the Caribbean, different age groups. You name it, we've tried to reach that segment. What it's confirmed for me is that many people are experiencing racism in the healthcare system, and because of that, don't want to trust healthcare institutions. According to some studies, more than 50% of Black people report past year discrimination in public spaces, which includes healthcare institutions, as compared to 12% for their white fellow citizens. So that just gives you a sense of the scope of the experience. But racism also acts through the social determinants of health, through housing, through employment, through income. And with this pandemic, many Black people are low income earners, more than 40% below the threshold. And in Toronto and in Ontario, if you earn less than $30,000 a year, that sort of suggests you're gonna have a hard COVID experience or severe COVID experience if you get COVID. And so there's that piece, social determinants of health. But then there's the historic piece, which many people talk about in these town hall meetings, which actually aren't that historic. We talk about the Tuskegee experiment in the US around syphilis and 600 Black men, which ended in 1972 through media reporting, and which was a very unethical study involving Black people. The vaccine producers, people have brought this up in town halls, and I knew about it before. Pfizer having an issue in Nigeria in 1996 around one of its products, not a vaccine, but an antibiotic, Trovan. Johnson & Johnson, up to last year, still having issues with Black communities across America around talcum powder, which was heavily marketed to Black women. On top of that, you know, we have governments that say, government leaders, decision makers saying systemic racism is not a reality. Race data does not need to be collected to understand what's happening with COVID. All of these things undermine trust, not just of leaders of these communities, but people who are in frontline positions, essential workers, PSWs. I've been meeting a lot of PSWs. Today is a day for PSWs. And so, you know, one of the surprising things is the amount of PSWs who don't want to get a vaccine despite the risks they face in their occupation. And when I ask them why, I get the litany of these issues. Healthcare providers can become culturally competent so that when they talk about vaccines with people who are Black or racialized, they don't do harm by invalidating the perspectives of the people who make such claims. You have to assume that if someone expresses vaccine distrust or mistrust, it has to be grounded in reason, even though it's something you may not agree with. So the focus has to be respectful listening, respectful engagement, share the facts, provide the science, the evidence, let them make the decision. Your work is to build efficacy. Focus on equity. You know, if equity was considered through all aspects of vaccine, from vaccine allocation, vaccine discussions, we would be further along. You know, we organized a Black vaccine clinic 2 weeks ago in one of the hardest hit areas of Toronto. And we were surprised. People were out there on the line 5 o'clock in the morning. And this is in a very vaccine hesitant community. So what that showed us was trust and an equity approach, which didn't involve registration. It was a walk-in clinic targeting Black people, worked. Partner with communities. Finally, educate your peers. It's often assumed that we health professionals are on the same page when it comes to understanding vaccines, talking about vaccines with our clients. And what we found is that that's not the case. Many people go on WhatsApp, and are influenced by what they see on WhatsApp or what they see on Facebook or Instagram. And you have to assume that a conversation is needed, that you have to actually, create a safe space to discuss all these things. Thank you.
Thank you very much for those perspectives. Another question is, and this one I will direct to Dr. Constantinescu. It's clear that there are many reasons, hospital, long-term care facilities and institutions have vested interest in getting their staff vaccinated, including to ensure that staff and patients are protected from COVID. What are some of the actions that health institutions can take to support their staff in getting vaccinated without being coercive?
Yeah, I think you're right. And that coercion and persuasion are no way to build vaccine confidence. I think some of the co-panelists actually addressed some of these issues, and Dr. Kenty spoke about this as well. But in some ways, the vaccine hesitancy among healthcare workers is quite similar to the general public. There are issues around confidence and trust, health agencies, in vaccine safety, complacency. Do they see the threat of the disease versus the benefit of the vaccine? And that really important issue that both Dr. O'Gorman and Kenty spoke about, which is accessibility or convenience when we talk about healthcare workers, because we know that not all healthcare workers come to vaccine confidence from the same place. We do know that if you're a woman, if you work part-time, if you are a personal support worker, you're more likely to be hesitant. So when it comes to addressing this, there are a few key things that we can address. So in terms of the message, the issue around safety is interesting. And what we have found when we have done research on the vaccine hesitant people in our own clinic is that platitudes such as vaccines are safe and effective, go ahead and have them, don't actually work the same way for the vaccine hesitant. They want people to address safety head on. And to stay away from platitudes, and again, trying to address that in a way that is personal to them. And finding vaccine champions that they identify with is also crucial. So it's not just about the message, but who the message comes from. If it comes from their own communities, their own subspecialty or work that they do. And really key is accessibility. So making them easy to have the vaccine, overcoming technology, language barriers in how they book appointments, getting sick days for healthcare workers. This is a huge hurdle when it comes to hesitancy for healthcare workers. Lastly, what's really interesting is that needle pain is a significant barrier to healthcare workers in influenza vaccine. So 27% of hospital workers are actually report that their reason for avoidance of this vaccine is needle fear. Now, with the COVID-19 vaccine, it's been very interesting because it's a 2-dose vaccine, and there's been a lot of talk about the reactogenicity of the vaccine. So we can actually address this. So when we make this more accessible to our healthcare workers, we also need to train the vaccinators to use the positive language that helps with needle pain and needle fear. Such as validating the decision to come and have the vaccine, providing constructive feedback, such as you're doing a good job relaxing your arm. Those little things will actually play a role in people having their second dose, which we now realize is more, we've always known, but now there's even more evidence that that is really crucial. So I think those are some of the things: addressing safety head on, addressing needle pain, and accessibility being really key for this group.
Thank you very much for everyone. And now there are some more live questions from the audience. And as the age of vaccination is lowering slowly, what are some of the challenges and some ideas and strategies to overcome hesitancy in the younger population? So the older individuals ran to get immunized, understanding the risk, but how do we support younger adults and teenagers? Who wants to take that first?
I can start with this one, seeing I'm a pediatrician and a parent. So with a double application here. I think it's a true milestone that we can finally protect our teens and in some ways give them back a sense of control. And kids have felt very out of control in this pandemic. And now we're seeing that they've paid a huge price. We're seeing so many mental health admissions, such a cost in terms of socialization and education in children over this pandemic. And from the kids I've spoken to, many of them feel responsible and as a threat to their families because they've been the ones, often the only ones leaving the house, going to school. So these are really crucial recognitions that we're coming across, understanding the cost of this pandemic to kids. Now, when it comes to vaccine hesitancy among parents, the approach is similar to adults. So the same idea of connecting, meeting them where they're at, keeping the conversation personal. But from our own experience, we've also found that if you're going to pick one thing that's going to always dominate the hesitancy around this in children and the vaccination decision is safety. So the issue of long-term effects and safety, even before COVID, now with COVID, still the main driver of hesitancy. And we know that this is more than just correcting misinformation. There is that whole validation of the emotion. So I'll tell you a few pointers that we've also found effective in terms of when you pass that personalized message to them. Always keep it personal, relevant to the child and the family, which means you have to learn a bit about the child and the family to be able to keep it personal for them. And then the message again, safety head on, stay away from platitudes. Instead of saying vaccines are safe and effective, mention the 2.8 million teenagers in the US who are 16 and 17 who've had these vaccines with no specific safety concern. Outline the robust immune response to the vaccine that we're seeing in teenagers. And again, outline that kids have paid a heavy cost to this pandemic, and therefore there is great benefit in them having this vaccine.
Excellent. Any follow-up from any of the other panelists?
Covered it.
Okay. Very good. Another question. Can you please comment on the fact that a lot of individuals who are hesitant, there's feeling more fear and feeling based. Sharing more facts doesn't always help. How what are some other strategies to overcome that?
Well, I think we've talked about it. It's all about trust. This is not a question of providing one set of evidence to counter another set of evidence. It's being a trusted source of facts or trusted source. So, our task force really recognize early, it's not about the evidence, it's about trust. And we have to sort of respect the people who we are engaging, provide some respectful listening, provide as much evidence as the conversation will allow, but focus on building efficacy for the people to make an informed decisions. And if they choose not to make an informed decision about the vaccine, come back later. Say, you're not ready to make that decision now. I respect that. Let's have the conversation again sometime later. So, accept that the person's validity for making that decision. Very important.
Thank you. And leaving the door open for future discussions is an excellent point. And I will ask Claire to comment maybe on population-based. I understand everything about building trust and all of that every panelist has said in different ways, but we have a lot of individuals who don't have a primary provider and don't have someone that they can really toss the ideas around. So how do we approach it on a population level, Claire?
Yeah, great question. And there are a number of people who don't have that primary care provider, and but they are often accessing other social services or other healthcare services. It's rare that someone's not accessing anything at all. And so, for example, I've done some interviews with vaccine providers across the country and heard a really lovely example out of BC, where the outreach nurses who spend their time in community, they're familiar with the population that they're serving. They set up a vaccine table right on the street, and we're providing vaccines right in community, really embedding it, and working with peer support workers who were those community ambassadors who could go out, let folks know that the vaccine clinic was available, answer questions, share their own experiences of being vaccinated, and kind of almost recruit people to that opportunity and allow it to be there. And as you said, that ongoing opportunity, that open door policy, if you plop in once and that's the only chance, you're certainly not going to see everyone in terms of time, but also people need those multiple opportunities for engagement. It cannot be a use it or lose it kind of situation. And so using those services that have those ongoing relationships. Here in Calgary, for example, an outreach team is off doing, offering vaccine to encampments and trying to connect with people who are less engaged with our more formal healthcare system, really getting out there, getting into community, showing face and doing it repeatedly is really important.
Thank you. You reinforce the fact that we can't be one size fits all, and multiple opportunities are needed for sure. For individuals who are low risk and less concerned about the disease itself, what are some of the ways to give better information and to try to overcome this lack of perception of risk? Maybe Dr. Rashid?
Yeah, and I think this builds on what my colleagues were suggesting earlier in terms of vaccinating people who are younger. So I've got an 18-year-old at home, and we have this conversation frequently. So absolutely, I mean, the risk of severe illness is lower, but it's not that the risk is zero. It's not that we're absolutely clear about long-term side effects in people who are young. And I think the other thing that Dr. Constantinescu spoke to very strongly is that young people are noticing the impact of the restrictions on them. So, just having that conversation that, yes, absolutely, once the majority of us get vaccinated, we're all assuming that these barriers, these lockdowns are going to lift. But in particular, this is the way for young people to get access to the world's, to the lives that have been curtailed over the last few months. And I think, for my 18-year-old, that has much more resonance, right? That they're going to be able to spend time with their friends, to go out, to engage in those activities that are so meaningful to them. The notion of preventing ICU admissions and looking at efficacy data and side effect data, I think is not nearly as compelling.
Excellent. Thanks. Any additional comments from any of the panelists about that or any of the previous questions? As we are approaching our time to start wrapping up, so we have about 2 minutes, so maybe I'll give 30 seconds for each of the panelists to say their take-home message. I'll go clockwise. Dr. Constantinescu.
My take-home message on this is that it's great that we're talking about vaccine hesitancy, but right now most Canadians are vaccine confident, and we're really riding a wave of confidence. And I just want to say thank you to all the people who are working on this and all the non-medical people who have become vaccine champions, all working together to beat this. And we are closer than ever. And I'll stop there.
Thank you very much for the inspirational words. And then Dr. Rashid.
Yeah, I would echo the same thing. I've seen a dramatic shift in the last few months in the populations we serve. Two very quick things. Those are the people who are connected to us. And, although maybe it's a bit of a tangent to this particular conversation, it is so important that vulnerable populations are connected to primary care, right? For this reason, and screening for TB and blood pressure and everything, right? And when we see these kinds of events and we see people who are using walk-ins and episodic care, there's just a limitation to what we can leverage. The other thing, and this has been a huge issue in Ontario, as I mentioned before, so many of our patients want the vaccine now. They've gotten past their hesitancy. It is a mess to try to actually book that appointment, right? And, although there's been a push to streamline systems, this whole idea of making it accessible is something we've really got to take advantage of and do it quickly, because we are missing opportunities.
Absolutely, I'll echo that. And Claire, a few final sentences.
Yeah, I'm just really excited to see this wave of confidence and hope that we can ride it by making convenience part of this and making it accessible to those facing the greatest barriers to access, but also the greatest impact of this pandemic.
Thank you, Dr. Canty.
Thank you very much for the opportunity. Two things: equity and access should be primary considerations, not secondary afterthoughts. You know, I support the population approach, but it has to be targeted universalism built into that approach so that people who are at greater risks get priority for vaccination. That's number one. Number two is we live in a globalized world, thus the pandemic. Not to think about healthcare workers in other countries who are at high risk of getting a vaccine, a high risk of getting COVID, but of limited access, with limited access to vaccination is it's an ethical challenge. I think we really need to give second thought to rethink. So we're talking about vaccinating children who are at low risk, but we also need to think about health professionals in many countries around the world at high risk who don't have access to vaccines. I think those mutations are coming if we don't help them address COVID right there.
Thank you for all sharing your thoughts. I truly believe that equity should be a primary consideration, and removing barriers and ensuring access and doing away with appointment systems should be a priority, and we should use the enthusiasm about vaccines that is existing to propel that to greater rates of immunization. With this, I would like to thank you so much, and to conclude this webinar. I remind you that NCCID will be hosting more Public Health Agency COVID webinars. For more information, you can visit our website at nccid.ca, where you can also find the slides from today's presentation, and the recordings will be there shortly. Upon exiting, please fill the evaluation survey, and specifically we're interested in that as we plan the next activities. So help us shape what is relevant to you. Many thanks, and have a great afternoon.